Welcome to another episode of the Senior Focus. I'm your host, Attorney Nick Kaltzis. How old is geriatric medicine, you might say? Well, the first book to offer instruction in the care of the elderly was written in the year 1025. What's our topic today? You guessed it, geriatrics, the branch of medicine that deals with the diagnosis and the treatment of diseases and problems affecting elderly people. We'll be joined today by Dr. Catherine DuBeau. Dr. DuBeau is Clinical Chief of the Division of Geriatric Medicine at UMass Memorial Medical Center, and Dr. Joe Fahed, Chief Medical Resident. And of course, Don Osterguy joins us. The Canon of Medicine, written by, let's see if I can say this right, we'll say Avicenna, was written in 1025, so a long time ago. The care of elderly people was started many years ago. They recognized there's a difference in the treatment of, we'll say, the adult population and the geriatric population. A lot of people don't realize there's a difference between the two, but there is, isn't there?
There definitely is. But even though some of this goes back many centuries, as a specialty, geriatrics actually isn't that old. And there's been an increasing appreciation that there is a significant difference between taking care of a middle-aged person and an older person, particularly if they have multiple diseases, if they have more problems with getting around, and especially if they have problems with their cognition and memory.
And the idea of having someone who presents with a multiple of different medical conditions is something, I mean, I'm not a physician, but I would assume is rather common in the geriatric population.
Oh, certainly. It's uncommon that one of our patients has just one condition. I mean, we do see people who make it into advanced old age who are very healthy, but most people have multiple conditions. They take multiple medications for them, and these they can interact with each other, the diseases and the medications, but they also...
It's kind of frightening, actually, if you think about it. I mean, the idea of drug interactions, I always thought that, maybe in a nursing home, there can be over-medication. The staff at the nursing home doesn't want to see, the elderly person, walk around the facility, or maybe they don't have the manpower to provide care for all these different patients. So, they administer a rather strong, at least, in my estimation, a rather strong medication, and not knock the person out, but curtail their activities. I didn't realize the number of different medications that a lot of elderly people take.
Certainly. About 2 out of 3 older people take at least 5 medications, and we know that 1 out of 5 takes 10 or more medications. So if you're older, you take a lot of medications.
I'm doing pretty good then, because I only take 1 medication for high blood pressure.
You're not older.
Thank you. I appreciate that, Joe. I appreciate that.
But one important thing to note in this it's natural that as you grow older, you get more conditions, medical conditions, and therefore you need more medications. However, also your body is getting older, and those same medications do not work the same as when you were younger. And this is where a lot of confusion comes, that it may be natural to take more medications, but it's more toxic for your body. And this is why drug-drug interaction is much more important in this population rather than others. And we're going to talk about it later on, I guess, that some of the guidelines or recommendations that we recommend for all adult population, which are middle-aged, to be clear, would be different than what we probably recommend for elderly populations because of the side effects are toxic.
Is it appropriate for me to ask you the difference between adult medicine and geriatric medicine? Is there a differentiation between the two?
Oh, definitely. In geriatric medicine, we not only take into account the specific diseases, we look, many of our patients, and we have expertise in geriatric syndromes. These are maybe not diseases, but conditions that we see commonly in older people, like problems with ambulation, getting around, Falls becomes a huge issue. Memory problems also. Loss of bladder control is another key geriatric syndrome. We also do a lot of end-of-life care and advanced directives and planning as part of our care. We also have a very holistic approach. I mean, many of our older patients, as they get frailer, have caregivers. There's family involved, spouses, and then other caregivers perhaps who come into the home. So it's a much more complex system that we're trying to coordinate. And that's one of the hallmarks of geriatric medicine as opposed to adult medicine.
You know, I think that what I'm hearing is it's all about the quality of a person's life, end of life, care. That's something I talk about frequently, not so much from the medical perspective, not so much from the care, but I always tell people, when a person is legally able to do so and they have legal capacity to do so, it's to their advantage to execute documents so that, let's say for instance, in the medical field, if a person's not able to communicate what their desires are, appoint someone you're able to do so that can stand in your shoes and let the provider know what it is the person's desire.
Exactly, just as much as a doctor for middle-aged people, younger adults would look, have you had your mammogram? Have you had your colonoscopy? Right. One of the things we're always checking is, do you have a healthcare proxy? That is as important as any of these other preventive measures that we do. So that's very important. And as you say, we also spend a lot of time on what someone's goals of care are. And those can become very different across a group of older patients. This comes into what is particularly when we're talking about more invasive care. There may be people in their 80s for whom some invasive, let's say cardiac care, isn't totally appropriate. There's others for whom that's really not going to prolong their life significantly, or it would prolong it in a way that doesn't give them the quality of life. So that's one of the things I enjoy about geriatrics, is it's very variable, because the older people are, the more variation there is between them. And if you want to elaborate on...
I wanted to add to what you started, Dr. DuBeau, with how to treat a patient as a whole. And this is very important, because one of the first things we learn in medical school is you treat a patient and not as a whole and not a disease. So we're not training you to train a different disease disconnected, but treat a patient as a whole, with their social history, social aspects, and desires. And the funny thing is, the one who started this, who quoted this and taught this to his pupils, was Avicenna himself.
Way back in
1,000 years ago.
When we were at the Lincoln Senior Center today, I couldn't stress enough the importance of people to, when again they have the requisite legal capacity to execute at least a healthcare proxy, so that, and it was an Alzheimer's seminar, and some people were there, and it's a sad thing, whether it's a spouse, whether it's someone's parent suffering from some kind of dementia, very sad thing. And I tried to explain to them the importance of, when a person has the capacity to do so, it's really important that they execute surrogate decision-making documents, specifically, in this field, healthcare proxies. The mere fact that an individual has a diagnosis, whether it's Alzheimer's or some kind of dementia, that doesn't mean right at that time, that's it, they've lost their capacity, they can't do so. It's important that they act quickly and that they execute that healthcare proxy, so that someone's in a position to let you know what the person would want and not want. With respect to what a geriatrician does, what is your typical day like?
My typical day. Well, I had a fairly typical day yesterday of seeing patients in the office. It is a combination of people I follow for their primary care, or really what it is longitudinal specialty care in geriatrics, because
Those are big words. Longitudinal specialty care. Okay.
Okay, that means it is primary care, but it's in a sense specialized primary care, because we bring in our expertise in taking care of older patients. So I saw some patients of mine in their early 70s who are really quite healthy. They're the kind of person I might see once a year, maybe at most twice a year. Saw other patients who are much more frailer, have memory problems, and one of them in particular, the dementia has been advancing with some weight loss. So how are we going to deal with that, work it up? Are we going to work it up? Are we not? How are we going to deal with this or set expectations? And also there becomes an issue of are they living in a situation that can support them as they get frailer, need more help, need more supervision?
Now, we all know of the aging population, the segment of our society that's 65 years of age. I think I heard someone from Social Security told me at this point in time, 10,000 people a day turn 65 years of age. Now, I personally find that a rather staggering number. To translate that into a more understandable number, a typical patient that you see, have you seen a difference in, we'll say, demographics as far as age is concerned with respect to the care that's provided?
Is it actually not that much?
Okay.
I mean,
I think it will be.
Well, because I only see older
That's
patients.
true. That's true.
I only see older patients.
Okay.
But a lot of the people, if you looked at the average age of the people I take care of, it's around 80.
Okay, well, let me try this then. Do you feel that there are enough geriatricians to treat the demand for geriatric care?
Absolutely not. There is a profound shortage.
Profound shortage.
Profound shortage. We are not training very many people a year because we can't attract people into the field. It's seen as, it's a primary care field, which is hard to attract people into anyway. It's seen as potentially low paying because the major insurer we deal with is Medicare, and everyone's heard about potential Medicare cuts. And so it's hard to attract people in when you say, well, you're going to be seeing all these complicated patients and we're going to pay you less to do so.
I was going to ask you a politically charged question about Obamacare, but I'll shy away from that for now. And I'll say, do you think that it's a problem of education? Like if we know that the population is aging, I think at an alarming rate, but we also know that there's, I'll say, a shortage of geriatricians. Why do you think that is? I mean, other than like
some of the reasons I just said.
Right.
It's hard to attract people into the field for some of those exact reasons. So one of the things we've done in geriatrics, because we know we'll never have enough geriatricians, is train people from other specialties about geriatric care. And Joe's a great example of that.
So this is what we've been doing, working actively on it this year, training mostly the internal medicine residents, and from them with the students as well that we work with at UMass Medical School. More about geriatrics topics, especially that there's no core training just in geriatrics as of now, except when I do into a specialized geriatric fellowship. And again, it's very important because what we usually get trained at is how to treat a heart attack or a stroke related or separated from the other conditions altogether. However, when we have a patient and it's a whole package, and that's what we need to be looking at. We put together a couple of seminars and we've been working on it, and we have very good, nice feedback. And
we're going to have to go to a break right now, but when we come back, we're going to talk about when does someone need geriatric care.
Millbury Healthcare Center is a highly respected 5-star deficiency-free skilled nursing and rehabilitation center. We are renowned for our compassionate care and specialty programming, making it possible for your next step, returning home. We listen and take the time to understand your goals. We provide support and the tools needed to safely prepare for your transition home. Millbury Healthcare Center is the community choice for skilled nursing and rehabilitation.
Does your loved one suffer from memory impairment, dementia, or Alzheimer's disease? Consider Dodge Park Rest Home in Worcester. Our geriatric medical team and nursing staff are available 24 hours a day. We offer medication administration and incontinence care with dignity. Our activity programs are designed to engage and stimulate the mind. And with Dodge Park Rest Home, you can better protect your estate and save your assets with only a 1-year look back. Your loved one will feel safe and at home with Dodge Park Rest Home of Worcester.
Are you searching for health answers? Want to find the best local healthcare specialists? Go to chartertv3.com. Our weekly Health Watch covers all the local health news you need to know. Go to chartertv3.com and click on worcester.md. You can find the best local healthcare professionals, get articles, watch videos, and rate your doctor all with one click. So tune in to Charter TV3 or go online to chartertv3.com/health and access the best local health resources. Charter TV3 and chartertv3.com. Always on.
Do you have medications at home that you don't use anymore and you're wondering how to dispose of them? Safe disposal of prescription drugs protects children from accidental ingestion, as well as prevents prescription drug abuse or misuse. National Prescription Take-Back Day will be held on Saturday, April 28th from 10 a.m. to 2 p.m. at the Worcester Senior Center. Bring any medications that you don't use anymore for safe disposal. This service is free and anonymous, no questions asked. Call us at 508-799-8531 for more information.
Promotional message provided by the City of Worcester and Charter TV3.
Did you know that heart disease and stroke together claim more lives than any other cause of death? Scary but true. That's why the American Heart Association makes it their mission to build healthier lives free of heart disease and stroke. Join Charter TV3 in fighting heart disease and stroke at the 2012 Central Mass Heart Walk on Saturday, May 5th at East Park in Worcester. Every step you take will raise funds to support life-saving heart and stroke research. Help us beat heart disease.
I'm Kristen Doucette from Worcester News Tonight. Thank you for choosing Charter.
Welcome back to the Senior Focus. I want to talk about when it's appropriate for an individual, for a senior, to see a geriatric physician.
That's a great question. I think it's when people start to have a lot of different medical problems, are on a lot of medications, or have one of those geriatric syndromes that I talked about. They're falling, they're having increasing problems walking, cognitive problems, depression. That's where we can come in and look at, is this a combination of the medical problems that they have, or is it a medication problem? There's sort of a truism in geriatrics that any new symptom is a medication side effect until proven otherwise. I mean, we really value what medications can do, but as geriatricians, we live a lot in the world of some of the harms that medications can do in of themselves, or it's because they're not dosed properly for some of the physiologic changes that happen with age, or they're interacting with other medications, or they interact with a condition that the patient has. So for example, if you're someone who has problems with congestive heart failure and your arthritis kicks up and you figure, oh, I'll go take some Motrin or ibuprofen, well, that can interact with your heart failure and worsen your heart failure. So if you come to the emergency room, people would kind of treat you for heart failure and make sure you're not having a heart attack, and no one might look at the meds or ask you about over-the-counter meds you're using, because people frequently won't report those as on their medication list because they're not prescribed, and totally miss the reason why you came in.
Now we're going to talk more about drug therapy for the elderly and drug interactions, but I think what I'm hearing you say is it isn't based solely on a number. It isn't when
No.
someone turns the age of 60 or the age of 65. There are multiple systems, we'll say, in the human body, and when a person begins to see deterioration or problem with these different ailments, if there's a number of different things going on, it might be time for them to seek geriatric care.
I can give an example, Nick, with my mom. She had been to probably, I'll say, literally 12 different doctors. She was seeing someone for pulmonology. She was seeing someone for cardiac care. She was seeing her internal medicine person. She's seen a doctor for arthritis. She's seen another doctor for physiatry, I think it's called. There were probably so many. We were continually going to appointments. And it got to the point where there were so many ailments at once that she was getting discouraged. And she says, I think it's just my time to check out. So my mom finally seen a geriatrician at 82 years of age, as opposed, or 83 years of age, as opposed to maybe 60, 70. It's when all the ailments, we'll say, started coinciding, coming together, and we got to the point of, oh my gosh, it's another doctor, it's another doctor, it's another. It was crazy. We ended up going, actually, she's a patient of Dr. DuBeau's, and thankfully so. Everything was taken care of by Dr. DuBeau, and the beauty of it is that there are medicines maybe that she was either on that Dr. DuBeau looked at and said, because she is a geriatrician, Dr. DuBeau looked at and said, we have something that might be a little better. So instead of her breathing medication, we changed to something new, which actually helps her now and gives her more ability to keep going and exercise and all those great things. So I think it's a different aspect of when you see a geriatrician as opposed to a primary care physician. They have a little more knowledge, I'll say, at least in our case, in our personal opinion.
I think it's also important to highlight the fact that in the event a person has and sees a number of different physicians, the coordination of that care is something that can be greatly assisted by a geriatrician. Not to say that the geriatrician is going to be able to provide a number of different modalities of treatment for a number of different ailments, but the treatment of that person, like Dr. Fahed was saying, the whole body approach can be taken care of by one person. One person coordinate the care of many different physicians. I would assume it's like a team approach.
We try to, as much as possible. And that team also very often involves different professions. Nursing, case managers, social work, physical therapy. We work extensively with physical and occupational therapists. We also work with some providers, like psychiatrists, is needed sometimes. But we have all different types of, and attorneys sometimes as well.
Now, with respect to psychiatry, there is a segment of psychiatry devoted specifically to the care of the senior population, of the geriatric population. Is that correct?
Most definitely. Because in the way geriatric psychiatry differs is, even if you're dealing with some classic psychiatric conditions like depression or problems with psychosis, they may coexist with things like dementia. So it's a very different thing to treat, or behavioral problems that can happen in people with dementia. This is where geriatric psychiatrists can be very helpful. They're also very specially trained in the use of psychiatric medications in this population, and many of those medications do act differently in the body, or metabolize differently, or cleared differently because someone's older.
Now we're going to talk about that, but I also want to talk about my drug and supplement diary. It's something that is, we'll say, useful to the senior population, I would think, to fill out the form, indicate what medications they take, what the dosages are, so that when they see a physician, that information is available to the physician, so the physician has some basis upon which to decide what the interactions might be, what kind of medicine the person's on.
That's very true, and it's especially true when you go to the hospital or you go to the emergency room, that you have and bring with you, or family or someone else brings with you, an active medication list. Because we know the transition into the hospital and then out of the hospital back home are particularly vulnerable periods for medication changes and meds being stopped, meds being added, confusion, that can lead to people ending up back in the hospital very soon. This just happened to a patient of mine 2 days ago, where she had gone into the hospital for one problem. They had taken a list of what she was taking, and when she was discharged, left 2 medications off the list. And even though my patient realized that, she's a good patient. She said, they told me that it wasn't on my list, so I wasn't taking them. So very quickly, after a couple days, we realized, got to add those back. Do you want to talk a little bit from your perspective in the hospital?
I have a question for you. Is it right for me to say geriatric pharmacology, or is it called something else? Did I make that term up?
No, well, we can say there's if pharmacology is different geriatric population, but the term that we mostly use is not pharmacology, but polypharmacy in our mind. And polypharmacy...
So that's a nice way of you saying, yes, you did make that term.
I didn't say that. We refer to polypharmacy as one someone or any patient takes more than 5 medications per week. This is by definition what polypharmacy is. And from all the studies we did, we know that if you are in the polypharmacy group, you are at higher risk of getting all the side effects or higher risk of getting admitted to the hospital from medications. And there was, not so long ago, there was a very recent study that looked at the ED visits to the ER, and there was a lot of visits and admissions to the hospital just from medication side effects. And there's few medications that are medically indicated, but you need to be a little bit more cautious when you take them because those are the ones that have side effects, and those are important.
Dr. Fahed, I don't know if it was you that told me or Dr. DuBeau, there was one patient, they were on like 25 different medications. That's an astronomical number. I can't even imagine that.
Well, that's a great point. I mean, it was actually one of my patients, and as a geriatrician, I guess, I mean, part of me is embarrassed in a way. Oh my goodness, you have a patient of 25 medications. But this patient's a great example that they need every single one of those medications. And we go over the list. This person has a bunch of very complex conditions, many of them. And we would try to get rid of them as soon as we could, but right now he needs them. So even though people may be on very high numbers of medications, they may need them. But at the same time, one of the things we do in geriatrics is constantly revisit the list. Is there, for every medication, is there a diagnosis? Or maybe that diagnosis isn't there anymore. People get started on medications and they stay and stay and stay on them when the indication for it or the original need actually no longer exists. And what we're finding out over time for a lot of these medications that we thought, oh, so what, you know, what's the harm? There actually may be harm for people staying on them long term.
There's a certain expectation when a patient goes to see a physician with a problem that the physician will end up the visit with a prescription. Because if you don't end up prescription, you didn't solve my problem or my disease. And if we add all those prescriptions all together with every single physician visit, that's where problems start. It's very important, as Dr. DuBeau said, especially for this population, that every new symptom is actually a drug side effect until proven otherwise, which means if I'm taking a medication, that medication caused me dizziness, let's say, instead of adding a dizziness medication and now I'm treating the side effect, I'll just have to take the first medication out and look for something else.
So, as far as I can tell, this My Drug and Supplement Diary, very important for people to get a hold of it and to fill the thing out so that when they go to a physician, the doctor knows what medications the person's actively taking in determining what medication they may need to prescribe for a particular ailment that they're suffering from.
I want to add to
Yeah.
this.
Of course.
This needs to happen at least every 6 months, once every 6 months, so twice a year. And all the medications, non-prescription medications, should be added as well, like over-the-counter or herbal medications, because there's a lot of interactions with those ones as well.
If you go to the pharmacy
Yeah.
now, it's amazing because you'll see I've never seen, I went to a pharmacy one day and I looked, there had to been one entire aisle from front to back of the store just on supplements and vitamins, where I don't remember years ago being like that. My mother wanted to try one for arthritis, one for cholesterol, one for this, and I'm like, you have to check with your physician first, your geriatrician, to make sure that's not going to interact with even the general medication you take. Would you say that's a suggestion that those could interact with that, Dr. Fahed?
I actually have more to say about the multivitamins and over-the-counter medications.
Well, then I'll tell
Yeah.
you what, we'll go to a break right now. When we
Okay.
come back from the other side of the messages we're about to hear, we're going to talk more about polypharmacy.
Great.
Does your loved one suffer from memory impairment, dementia, or Alzheimer's disease? Consider Dodge Park Rest Home in Worcester. Our geriatric medical team and nursing staff are available 24 hours a day. We offer medication administration and incontinence care with dignity. Our activity programs are designed to engage and stimulate the mind. And with Dodge Park Rest Home, you can better protect your estate and save your assets with only a 1-year look back. Your loved one will feel safe and at home with Dodge Park Rest Home of Worcester.
Millbury Healthcare Center is a highly respected 5-star deficiency-free skilled nursing and rehabilitation center. We are renowned for our compassionate care and specialty programming, making it possible for your next step, returning home. We listen and take the time to understand your goals. We provide support and the tools needed to safely prepare for your transition home. Millbury Healthcare Center is the community choice for skilled nursing and rehabilitation.
Join Girls Inc. of Worcester at its annual Girls Celebration, honoring teen girls and community leaders with guest speaker Cheryl Ann Gangle, founder of Be Like Brit, and a special presentation by our expressive arts performance troupe, Dear World, Voices of Worcester Girls, on Thursday, May 3rd at the Manor Restaurant in West Boylston. For additional information or for tickets, please visit us at girlsincworcester.org. Charter Communications and Charter TV3 are proud sponsors of the Girls Celebration. Are you searching for health answers? Want to find the best local healthcare specialists? Go to chartertv3.com. Our weekly health watch covers all the local health news you need to know. Go to chartertv3.com and click on worcester.md. You can find the best local healthcare professionals, get articles, watch videos, and rate your doctor all with one click. So tune in to Charter TV3 or go online to chartertv3.com/health and access the best local health resources. Charter TV3 and chartertv3.com. Always on. Consider donating new or gently used books at sites around Worcester for the 6th annual Worcester, the City That Reads book drive. The committee hopes to collect 26,000 books this year, with the goal to provide summer reading material to children who may not otherwise have access to books. The books for children in pre-kindergarten through grade 8 are being accepted at this time. Donations are accepted at the following locations, and book collections are also being held by Worcester Public High Schools, Worcester colleges and universities, private schools, and organizations.
I'm Melissa Tupin from Worcester News Tonight. Thank you for choosing Charter.
Welcome back to the Senior Focus. I want to talk about polypharmacy. We've been talking about medications. I want to talk more about medications. Are there common medications and prescriptions that are written for the elderly population?
Well, we were talking before about multivitamins, and they can be prescribed or people self-prescribe them, but they're not innocuous.
But in general, you only need multivitamins if you have been deficient with vitamins. And vitamins is a Latin word for trace elements, which means we really don't, our body has storage for up to 5 years. For example, for vitamin B12. 5 years if we go strict vegetarian before we need vitamin B12 supplement, just to give you an example. So if you have variety of diet, you don't really need multivitamin supplements, except maybe if you're a pregnant woman or a dialysis patient. That being said, a lot of people just cannot get away from their multivitamin pill because it just makes the whole difference for them in their day. Just to give you an example, those are not innocuous. For example, when they looked at vitamin E, whether or not this helps with prostate cancer, because there was thoughts that may prevent prostate cancer. And when they gave vitamin E versus placebo to all those people, actually the group with vitamin E and selenium, I guess, has increased risk of prostate cancer. Just to say those are not innocuous and they're not proven to be used. I also want to say those are over the counter and we don't know what other ingredients in there in that pill and how might that interact with the prescription medication that the patient or their body really needs, especially in this elderly population that we're talking about today.
And adverse drug reactions. There are probably a lot of people out there that are watching and they think, well, you know, the medications were prescribed by a number of different physicians and they can't hurt me because they're prescribed by different physicians. But you hear a lot about adverse drug reactions. What about, for instance, the multivitamins? Someone thinks to themselves, well, it's a multivitamin. It's not going to have any effect on the other medications I take. What would you say about that?
So for example, that every single medication, this is a rule, every single medication has adverse effect on it or impossible. Now different percentages. But for example, very important one, blood thinner. So you use it to prevent stroke, let's say, if you have, or to prevent blood clot and then stroke. However, what is the risk of that? That even a small fall can cause you bleed into your brain and then you die from it. So this is why for every single medication that we prescribe, especially in this population, we always weigh the risk and benefits. And this is why two patients cannot compare to each other with same condition, because as we said earlier, it's a whole patient that we're treating and we looked at some other conditions as well. That's the diabetic medications as well.
But you can't let the pendulum swing too far the other way, because even, for example, of blood thinners, which we use for atrial fibrillation, people sometimes get afraid to use these medications in older people. And when people have specifically studied this, they found that actually older people did get benefit from the blood thinner as opposed to aspirin. A lot of people would put the older person on aspirin instead of the blood thinner, saying, oh, that would be safer. Well, it may be safer for bleeding, but it was much higher risk of stroke. So just because you're older doesn't mean that the drug could be bad for you.
It's been around for so long that you think about it, that they say that, oh, you need an aspirin a day to prevent heart attack. I mean, commercials galore, honestly, on that. And it makes you wonder, I mean, if they have medications specifically for that, like prescribed medications that may do a better job at treating something, maybe that's the way to go instead of just, I think it's the old adage that it's been around for so many years, you're thinking, how long has aspirin been on in the population that we've taken it, and yet they've come up with so many more new drugs that may actually help in more ways than just that aspirin or cause side effects.
Or the other thing is people might continue their aspirin and take the newer medications, which increases the risk, let's say, of stomach bleeding. And even drugs that we thought were very safe and we thought people really should stay on forever. For instance, the drugs for osteoporosis. We used to put women on it and think, well, you should stay on this to keep your bones in good shape. We now know that women who've been on it for longer periods of time, like 7 years or longer, actually are more at risk for a special kind of fracture.
Right.
And this comes out more and more. So people are now, I think, more appreciative that just because something is good for you at one point doesn't mean you're going to need to be on it for a long time. The enthusiasm for putting everybody on a drug, for instance, like aspirin for heart attack or the statins for high cholesterol, we're being a little bit more cautious or thoughtful about the way we prescribe that now. Does this person really need these medications? And part of that's out of the appreciation that there is no free lunch with the medication.
Also, to add to this, for example, for statin, whether or not to start an 82-year-old on a statin or not, the question we know is beneficial. Question is, how long does it take so that you can prevent a heart attack? If it takes years, it's not worth for you to give it to you, but it may worth for a 45-year-old who is, let's say, smokes or have some other cardiac risk factors.
Without being too technical, are there medications that are commonly prescribed to the senior population or to a geriatric patient that is common to adverse drug reactions?
Well, I think Joe alluded to two big classes that came out of this study looking at emergency room visits for adverse drug reactions. And the great majority of those were due to only really two classes of medications: diabetes medications and blood thinners. Now, they're two good examples of meds that people often need, but they may not be trained to monitor them. These are medications for whom there may be only a very thin line between enough medication to treat the problem and too much causing a side effect. There's also medications we know that have a much higher risk in older people. The American Geriatrics Society has recently revised a list of these medications. The list is commonly known as the Beers criteria, after Dr. Mark Beers, who initiated this. And on the Beers criteria, we have three categories of drugs. Drugs that are really potentially inappropriate to use in an older patient because of the higher risk of side effects, or the side effects far outweigh any benefit. There's a second category of drugs that we know really should not be used in people with certain conditions. So, for example, a patient with congestive heart failure should not be given ibuprofen or naproxen. And then a third category are drugs that should be used with caution in older patients, in which you really have to weigh the risks and the benefits, or for whom there are some data suggesting increased risk, but it's not strong enough to say you really should consider avoid them. At the same time, this list is not meant to be black and white, because we know we're looking at overall in general, but when it comes down to an individual patient, it still may make sense to have them on one of these medications. The list is there to serve to remind you that there may be problems with this. You especially need to watch out for it, but it doesn't mean that you should never use this medication. Certainly there are medications on that list that I think most of us would agree we would never use. They tend to be older medications, and also medications for whom we have much better alternatives now, particularly some like the antidepressants. Some of the older antidepressants caused a lot of problems, and we have newer ones that are safer.
So I think that what I'm hearing is not only important that you go to the right physician, but also that when you go there, you have a list of all the medications you take, because there really will be and can be interactions between the medications a person takes, and as you had mentioned before, whether it's a balance problem with someone falling, there can be things that happen that are as a result of drug interactions.
Exactly. And sometimes, we also had talked a little bit before about reviewing the medications to see, do you still need it? So it's not so much, do I need to add anything, but I've sometimes said that one of our favorite indoor sports as geriatricians is stopping medications. Joe, do you want to talk a little bit about, because it sounds like
we've got about 30 seconds left, and the one question I wanted to ask, and I'll direct it to Joe, is it better to stop a medication cold turkey or to taper off that medication?
This is a very good question and a very important question, because it's important to stop medications as it is good to start medication for the patients who need them. For the sake of time, I just want to say every medication we start slowly and then we go up, or the medication that we need to stop slowly and then stop it afterwards. If you take a pill, let's say for your stomach, you can, it's like multivitamins, we can just start it or stop it. If you're taking an antidepressant, then we're going up on this. When we want to stop it, we need to taper it down before we stop it. And the main reason is if we stop it cold turkey, we have a withdrawal side effect that we can see either from the from the underlying condition or from medication itself.
Well, that's it for today's show.
No, all right, segment 3 again.
Runs.
We
Okay.
have one more.
Go ahead.
Are we into a break now? I don't think
No,
that
no,
at
we're
the
not
end.
into a break
Okay,
yet.
Yeah, all right. As far as steroids, I know that when, I'll give you an example, myself or my mother with the steroids, you have the issues of that you have to, at least for my physician, wean off, come slowly up, because there are adverse side effects to it. I know when my mother was on them, she went up and started, I'll say, a 5-pill regimen, and then started going down slowly. And that's, in a sense, what your body requires even to come off of them. And you see that with so many other, we'll say, instances of medications where you just don't want to stop cold turkey for the fear of that, the adverse reactions of stopping cold turkey, worse than just, and that's the scary part, especially for a senior. Some already exhibit dizziness, in all honesty. I know my mom has little bouts with it here and there that, you know, we're trying to do the lose weight and the exercise more and all those other things added into it. The scary part is when you add in new drugs, you have to worry, could it because of that? And I know that when we've seen Dr. DuBeau many times, we go over that medication list regularly. My mother has gotten to the point where she says, oh, that again? Because it's a long list. And we go and check off every one, but that's the important part of it. Before you get to see the doctor, that you've got it already, and they know what they've seen and what they've had. So,
and it's good for the physician as well, because it makes us look at the list and say, why do I have that person on that medication? Is this something I should reconsider? It's always a good practice, because as I think I mentioned before, the indication may have changed, or they really don't need it anymore. They're better for one thing or another. And this particularly for medications that people think are relatively innocuous, but which can cause side effects. And the other thing is, for every extra med you take, you're increasing the number. So it's very easy to get over that magic number 5 medications, because after that, the chance of an adverse drug effect goes up markedly. It also, once you get over 5 medications, the chance you're going to take all of them goes down. It's just human nature, keeping track of all those medications.
and as you age, honestly, I mean, I look at my mom's pill counter, and we make sure of it. You know, that's scary when they get older, that you have the memory to make sure that you're taking them all.
We're going to head to a break right
And
now.
come back.
We're going to come
And
back.
we'll come
We
back.
will come back.
Millbury Healthcare Center is a highly respected 5-star deficiency-free skilled nursing and rehabilitation center. We are renowned for our compassionate care and specialty programming, making it possible for your next step, returning home. We listen and take the time to understand your goals. We provide support and the tools needed to safely prepare for your transition home. Millbury Healthcare Center is the community choice for skilled nursing and rehabilitation.
Does your loved one suffer from memory impairment, dementia, or Alzheimer's disease? Consider Dodge Park Rest Home in Worcester. Our geriatric medical team and nursing staff are available 24 hours a day. We offer medication administration and incontinence care with dignity. Our activity programs are designed to engage and stimulate the mind. And with Dodge Park Rest Home, you can better protect your estate and save your assets with only a 1-year look back. Your loved one will feel safe and at home with Dodge Park Rest Home of Worcester.
Did you know that heart disease and stroke together claim more lives than any other cause of death? Scary but true. That's why the American Heart Association makes it their mission to build healthier lives free of heart disease and stroke. Join Charter TV3 in fighting heart disease and stroke at the 2012 Central Mass Heart Walk on Saturday, May 5th at East Park in Worcester. Every step you take will raise funds to support life-saving heart and stroke research. Help us beat heart disease.
Do you have medications at home that you don't use anymore and you're wondering how to dispose of them? Safe disposal of prescription drugs protects children from accidental ingestion, as well as prevents prescription drug abuse or misuse. National Prescription Take-Back Day will be held on Saturday, April 28th from 10 a.m. to 2 p.m. at the Worcester Senior Center. Bring any medications that you don't use anymore for safe disposal. This service is free and anonymous, no questions asked. Call us at 508-799-8531 for more information.
Promotional message provided by the City of Worcester and Charter TV3.
Tired of weather reports that don't focus on Central Mass? Introducing Worcester Weather, the only video weather report for Worcester. Worcester Weather is easily accessible 24/7 by visiting chartertv3.com and is updated throughout the day to give you the best video forecast possible. Worcester Weather also airs at 5 p.m. during the Jordan Levy Show and every Worcester News Tonight telecast. Worcester Weather gives you the local forecast you have always wanted. Worcester Weather on Charter TV3 and chartertv3.com. Brought to you by Berterra Nissan of Auburn.
I'm Andy Lacombe from Worcester News Tonight. Thank you for choosing Charter.
Welcome back to the Senior Focus. I'm sorry I keep saying that the show is over and we have one segment left to go, but we have one segment left to go. Donna, I think you had a question with respect to medication.
Well, what we were discussing in the break was the fact that many times seniors will say, give each other advice on certain medications or vitamins or supplementation that maybe that will help someone. And I think the important factor is that they need to talk to their physicians about it. That's the most important way, because many of these drugs do interact. I know my mom was on a kick for a while about coral calcium, supposed to take away every arthritis pain that she had. And in the long run, she started on it and did nothing. So it's all a question of, will it interact with her other medication? And there are so many commercials out there which lead people to think that this is going to be the almighty cure for everything. And it's really the doctors who have the knowledge and background to say, well, this has been approved by the FDA or whatever. I'd be very hesitant to say to my mom, it's okay to just go on something without asking in advance to make sure there are no drug interactions, because I'm sure there must be a huge amount of them. We just talked about vitamin D being a big factor for physicians, being low numbers. Is it all about, in a sense, testing to make sure, blood tests to check on these things and see where they're at?
For some of them. I mean, there are certain things like vitamin D is really the classic one, where we can check a level and determine whether you need supplements. Some people do, some people don't. Depends on your diet and how much sun exposure or sun exposure with or without sunblock that you get. The thing about over-the-counter medications is, even if they don't have effects or don't have any overt harms, they may not be doing any good. A lot of these have not been studied, or they have been studied. Like, for instance, glucosamine chondroitin may be helpful for arthritis in the knees, but not the hips or the shoulders, is what the studies suggest. So we do know some of this information.
If a person is concerned that they're over-medicated, are there common side effects that they should be aware of?
A lot, especially unsteady gait, falling,
confusion, somnolence. I mean, they will tell you, I feel drugged, basically.
Okay.
But
And
it depends also on the medication they're taking.
right.
and
They can have swelling in their feet,
Right.
and someone's told them, oh, it's varicose veins. It's like, no, actually, it's your blood pressure medication. I have this cough that's bothering me. Oh, take some cough syrup. No, it's your blood pressure medication that's doing that.
My mother had
That's
that
your
one,
mom.
same exact. That's what Yep, I remember that happening. So there are adverse side effects to taking those medications, and knowing that you have them, at least reporting them to your physician so that they can say, this might be part of this, let's change this medicine, decrease it, or stop it altogether. And that might be the key factor for it.
And that's particularly important for avoiding what Joe talked about earlier, is what's this prescribing cascade, is that people mistake a symptom as relating to a new medical problem when it's actually the side effect of a medication. So then what you're doing is treating the side effect of a medication with yet another medication without going back and stopping the original problem. And there's a number of examples of these over time. I mean, one of the classic ones is a study of people who were put on antipsychotic medication. And then you look a year down the line, and a large number of these people were also now on Parkinson's medications. It wasn't because they had Parkinson's disease. It's because the antipsychotics can give you symptoms that are similar to Parkinson's. So these people didn't need Parkinson's medications. They needed the antipsychotic brought down.
Is there a set criteria that you use in the event someone comes into your office and you determine too much medication, adverse side effects, or if you want to, we'll say, wean someone off a particular medication? Is there a particular set of criteria that you use in determining, a plan to get the person off the medication?
So it depends how the patient presents and what is chief complaint when they come to you. As we've been saying, it's very important to review the whole list. But for example, as we are taking the vital signs set, let's say the heart rate or the blood pressure is low, or heart rate is a little bit lower, and patients saying, I feel dizzy, doc, when I get out of my bed in the morning, because your blood pressure medication is a little bit high than what you need. And this is why in my mind, we go and focus our attention on the blood pressure medications or the beta blocker that may be affecting the heart rate or the blood pressure. So it really depends how the patient presents and what the complaints are. And in our mind, we link the complaints to the list of medication he has, and we think or not whether that's a side effect or not.
So instead of treating like a new ailment, you're looking at the whole picture and saying, possibly, let's try and wean, or we'll say, take some of this away and see maybe if that helps the symptoms instead of adding something new.
Or another thing it comes down to is what you're trying to do with the medication. If you have a person in their 40s or 50s with diabetes, you try to keep that blood sugar low to avoid long-term side effects. With an 80-year-old, if you kept that blood sugar that low, they're more likely to get into problems. At that point, it's less important for long-term side effects. So when I have someone in their 80s with diabetes, I tolerate a higher blood sugar or a higher hemoglobin A1C level than I would in a younger person. It's the same with blood pressure control, because I know if I keep somebody as low as I would for a younger person, they're going to be at risk for falls, for dizziness, etc.
I think that now we're at the end of our program, and I want to thank Dr. Fahed and Dr. DuBeau and Donna for coming in today.
And we just want to give Catherine DuBeau's number out, just
Okay,
in case
do
the
it fast.
Geriatrics clinic.
Do
Do
it
you know
fast.
that offhand,
Oh,
Dr.
sure.
DuBeau? If we can just let our viewers know that.
Sure. It's 508-334-6251.
Wonderful.
Thanks to all that are watching the Senior Focus.
Thank you very much.
Thank you.